Thank you, Ashanafi and Peter, and thanks to the Clinical Engineering Division of IFMB for this opportunity today. So, good morning or good afternoon to all the attendees. I will focus on the clinical engineers' perspectives on health technology regulations in Europe. I will try to be a bit informative, but also a bit personal, especially because I really think that the regulatory affairs can be both an interesting area and a professional opportunity for clinical engineers. So I'll give you a bit of context before that about the European Union, our continent, and the subset of the European Union countries. It's composed of 27 member states, members, and 450 million people. You can see that Britain is highlighted with their own flag as they are Brexiting. We'll see what's going to happen at the end of the year, but however, that's a big opportunity to share a regulatory market and a lot of experiences across Europe, and also 5 candidate members. I will talk about the legislative acts in Europe about medical devices, considering that the main legislative bodies are the Council, the Commission, and the Parliament. I will not focus too much on that, but mainly on 2 concepts that are very important in Europe from this point of view. The EU directives, that is a kind of legislation that is adopted at European level, but must be transposed in every single state with their own national legislation in order to be actually effective. But then we have the EU regulations, and EU regulations apply directly to all member states without any need to be adopted by each individual state. This is a very important difference, next slide, because the history of regulatory affairs in Europe dates back to the 90s with the directives on active implantable medical devices, on general medical devices, and in vitro diagnostics. So we are talking of 30 years of experience in regulatory affairs here in Europe, and very much has been done, and many issues have emerged. So that a few years ago, in 2012, there was the proposal of some new legislation about medical devices, and not more directives that must be adopted by each member state, but new regulations. Because, as I said, the regulations are immediately effective across Europe, so they give a framework that is much more consistent across all the countries. So in 2017, there has been the adoption of 2 regulations, one on medical devices and one on in vitro medical devices. These are very timely now, very up-to-date issues, because these were published in 2017, but the date of effective full application is going to be next year for the medical device regulation, and after 1 year in 2022 for the in vitro diagnostics. So really a changing landscape in Europe. Next. And this changing landscape gives both challenges, but as always, it also gives professional opportunities to clinical engineers, because we must know these regulations in order to do our daily job. One important thing that I always stress a lot when I talk about this regulatory context is that the main goal of the medical device directives and now the regulation is harmonizing the rules for the placing on the market and the putting into service of medical devices and accessories. So the focus is on the placing on the market of safe and effective devices. A lot of the things that we do in hospitals, like installation, maintenance, user training, and so on, is not strictly covered by this regulatory legislation. Yes, now, especially with the new regulations, there is much more focus on the life cycle of devices with post-market surveillance when something bad happens, and post-market clinical follow-up and so on. But a lot of the life cycle is not really covered by directives and regulation, and this is something that should be careful about. Next one. In fact, we have other European legislations dealing with installation, training, safety, maintenance and repair, and so on. And it's occupational health and safety, the protection of workers, because medical devices are working tools for the workers in a hospital, and it's also important for the safety of the patient. But these laws are not strictly related to medical devices, are much more general. The same about budgeting and financing, so the decisions about planning and procurement of devices, and the procurement itself with the tenders for purchasing equipment. There are EU directives on procurement, on accounting, and again, these are more general and not really specific about medical devices. Next one. As clinical engineers in different countries, there has been involvement in creating documents adopted by national ministries of health about the actual management of medical devices on the field, what needs to be done in the hospital. As an example, this is, I think, a very, very good document from the MHRA, so the regulatory agency in UK, about how to manage medical devices from the main principles of management to training, installation, maintenance and repair, and so on. But there is a strong difference between a document like this that gives some kind of a guideline compared to a mandatory legislation that is given by the directives, national laws, and the regulations. I think that for clinical engineers, being engaged in regulatory affairs is interesting and important, because we must know the rules of the game that the industry applies to certify their own medical devices, and they are important for us when we buy equipment to be installed inside of the hospital. But it's also an interesting professional opportunity, because a lot of companies may need now, especially in Europe with the new regulations, new competencies from clinical engineers to be involved before, when there is the design, risk assessment, usability assessment of medical devices. So these are really new, potential, interesting opportunities. Next one. And I went through the clinical engineers' HTM leadership principles that Peter showed in a previous slide. And I was thinking, which are the most relevant of these principles that must apply in order for clinical engineers to be really engaged in the regulatory process? So to know regulations, but also to affect how new regulations are drafted, approved, and so on. So I selected a few of these. So innovation culture, new technologies, 3D printing, cybersecurity, software, nanotechnology. These are important to know, and for many of us are not daily jobs, so it must be forward thinking. It's important because they are in the mindset of the politicians and the general public. So when it comes to regulations, we must be engaged with what's going on. Teamwork and gold drives, because we are not alone in our field. We must collaborate with other stakeholders, academia with the biomedical engineers, medical physicists, other associations, and so on. Evidence-based is one of the principles, because we bring to the table where the politicians are fighting with the industry and all the stakeholder powers. We bring evidence about patient safety, effectiveness of medical devices, and so on. Communication skills and soft skills. This is something that generally we as engineers are not really famous for, being able to communicate outside of our tribe or our technical lingo. So we must learn better how to communicate with other stakeholders and other people. And of course, integrity and ethics driven, because there are significant interests in the medical devices market, and we are helping to drive decisions with the principle of patient safety and better care. So I think that these are main leadership principles among the others that can be really important when it comes to affecting regulations from our perspectives. I would like to close with two stories next, because to make all these daily work in our activity. So COVID-19, of course, is the topic of the period. I would like just to tell you a first story about how we had to deal with emergency and the technology during the past months. As you may know, in Europe, the worst period has been between March and April and early May this year, where these are just a couple of the curves. We had huge demand for ventilators, multi-parametric monitors, personal protective equipment, and so on. And there was a problem, a really big problem in procurement of these devices and distribution and etc. Quantity, specification, legal problems, and so on. Next one. And what happened is that there were a lot of efforts from procurement agencies in the country, the government, but also generosity from other countries to donate equipment with issues. User interfaces in foreign languages, lack of user manual in national language, lack of CE mark. There has been officially no derogation to the directives rules with the CE mark. So officially, it was not allowed, even in the emergency period, to procure and install devices that had no CE mark, no manuals, and so on. But we were in an emergency, in a war-like situation, let's say. So what to do? As clinical engineers, next one, we interfaced with the Ministry of Health, with the General Management, Civil Protection, the Prime Minister himself, and we prepared a letter and a guideline with our professional suggestions on what to do during an emergency period with equipment that has not all the regulatory aspects in proper place. Next one. I will not comment the flowchart, but this is a flowchart about, is there a CE mark on the device, yes or no? If yes, let's check some things. If no, what to do? This was not applied during the previous emergency in April, March and April, but it can be useful now. The Ministry of Health responded saying that this is very interesting. And if there is a new wave of emergency, this could be actually applied, because our colleagues in hospitals will have the problem of devices coming into the hospital, need to be installed, but there is no CE mark, there is no user manual, and so on. So what to do? And we provided professional suggestions, having always in mind patient safety and effectiveness of devices as the main goal. Next one. Second story, about networking across Europe, with Peter here as a moderator and other colleagues across different countries in Europe. So we have Ireland, France, Spain, UK itself, Germany, Greece, Italy. We are networking, and we proposed a EU Federation of Clinical Engineers Associations, something to bring together at the continental level the experience of clinical engineers, to have one voice to talk with the EU Commission and EU Parliament. One of the initiatives that we did during the emergency has been this webinar, the 29th of April, where we discussed common issues and proposed solutions. Next one. One interesting thing we tried to do is to summarize what emerged and giving some suggestions for future directions. So main suggestions that emerged have been about rethinking the purchasing techniques in the different countries. Here is the example of France, but this applies to all the countries. Better coordination inside each country and across the different countries. And working on European independence, what does it mean? One of the issues with medical equipment has been relying so much on import from China and other countries. And in a global emergency where everyone needs the devices and protective equipment, you need local production in order to be somehow balancing the inevitable globalization and the local needs. So in order to enhance the value of our profession in this kind of crisis, we think that networking and communicating is very, very important. So next one, as a closing remark, I would like to say that these opportunities with the CD of the IFMB, the working group that Peter was mentioning, are very important to engage clinical engineers and network. And I think that all these regulatory issues are a challenge, because it's something that for many of us is not bread and butter, it's not our daily job for many when we talk of maintenance, installation, and so on. So it's a challenge, but it's also a big opportunity to provide our competencies and find new areas of professional engagement and work. So thank you all for the attention, and I'm available for the final Q&A after the other presenters. Thank you.